Thanks to the organizing community for giving me opportunity to present on this topic, dengue in special populations for the current webinar. I'm Tiang, infectious disease physician from Hospital Tuanku, Java, Seremban. This is my disclaimer. For the next 30 minutes, I will touch on the anticoagulant in dengue patients with VAF replacements and venous thromboembolisms. Also, antiplatelets in dengue patients with cardiovascular diseases who is taking long-term either mono or dual antiplatelet therapy. And the third one is the dengue patients with pregnancy. Case 1, a Miss CC1, 36 years old lady. She has mitral valve replacement for underlying severe mitral stenosis. She is taking warfarin 2 milligrams daily, compliance to medications. She is complaining of fever, arthralgia, myalgia for 2 days. Still able to tolerate orally, seems still well, ambulate around, no bleeding manifestations. Clinically appear well and physical examinations unremarkable. They did the dengue combo test for her, NS1 antigens positive, IgM and IgG negative. Here is the full blood count: white cells 6, hemoglobin 11, hematocrit 34%, and the platelets 108. And her INI is 2.5 with the FTTT of 42. Second case, Mr. ZA, 62 years old man, underlying type 2 diabetes, hypertension, BPH, and IHD with 2-vessel disease, recently stented with the drug-eluting stents. He was taking dual antiplatelet therapy on top of other usual medications. He presented with 4 days of fever, dizziness, and lethargy, associated with sore throat and cough during the first 2 days of fever. There was no sign and symptoms of bleediness. Clinically, he appeared tachypnic. Blood pressure and glucose seems uncontrolled. Heart rate highish, and the temperature settings, saturation is 96% normal. However, pulse volume is still good, warm periphery CRP less than 2 seconds. Lungs reduced entry over the right base. Abdominal got tenderness at the epigastric regions. Blood counts, white cell 3.1, hemoglobin 15, hematocrit 46.6 with the platelet 68. The pH is 7.4, PCO2 33, PO2 90, bicarb 18.9, and lactate 2.5. The dengue combo test NS1 antigen and IgG positive. Looks like he had secondary dengue. Now we reach a crossroad of the clinical decisions to manage the 2 cases that I presented earlier. Number 1, when to bridge the anticoagulants. Number 2, when to stop the anticoagulants or the antiplatelets. Number 3, when to reinitiate the anticoagulants or the antiplatelet if we stop it early on. Obviously, there are limited available evidence and no guidelines on how to manage anticoagulants and antiplatelets on such a case. So the risk of the bleeding need to be balanced against the risk of the thrombosis from interruptions of the anticoagulants or the antiplatelets. Hence, the case management is really case-to-case basis based on the expert opinions from various managing teams with extrapolated evidence from the non-dengue patients. However, the thrombocytopenia, platelet dysfunctions, and the coagulopathies in dengue fever are really dynamics. We have the safe platelet cut-off for the anticoagulants from the non-dengue patients. Tufano et al. Suggests that actually the mild to moderate thrombocytopenia of platelet counts more than 50,000 shouldn't be an issue for the VTE preventions. However, in the severe thrombocytopenia, the prophylaxis should be considered on an individual basis. The recently published expert consensus also suggests that the anticoagulations with low molecular weights at therapeutic doses for platelets between 50 to 100 is safe for conditions in acute and non-acute VTE. And actually the platelets of 30 to 50, the doses reduced to 50%. Just now we talked about the safe platelet cutoff for the anticoagulants. What about the interruptions of antiplatelet therapy? Is it safe? So now we look at the paper from the Singapore colleague. They looking at the safety of the temporary interruptions of antiplatelet therapy in a dengue fever with thrombocytopenia. This is actually a retrospective cohort study of adult dengue patients on antiplatelet therapy for both ischemic heart disease or stroke. And decision on continuation or discontinuation of antiplatelet therapy is made on the clinical ground in discussions with the patients by the attending physicians. The primary outcomes look at the composite outcome of major adverse cardiac and cerebrovascular events and all-cause mortality in hospital and for 1 year post-discharge. Secondary outcomes are platelet and blood transfusions and occurrence of dengue hemorrhagic fever, dengue shock syndromes, dengue with warning signs, and severe dengue according to WHO criteria. Relatively small number of patients in this cohort, 15 of them will continue antiplatelet therapy. 2/3 of them on antiplatelet therapy for ischemic heart disease, while 1/3 actually for ischemic stroke. 11 patients actually had PCI with coronary stents in the cohort. Comparing the two groups, those patients continue on antiplatelet therapy had a higher median Chausson's comorbidities index and also higher median platelet nadir. Only 5 patients developed non-fatal ischemic stroke. 2 out of 15 for those who continue, 3 out of 51 who discontinue antiplatelet. None of them actually had the coronary artery stent thrombosis or major cardiac event. So there's no difference between the both groups for the primary and secondary outcome. And from this paper looks like the clinical judgments based decisions on the continuation or discontinuations is safe. However, more study needed for the conclusions. We look at higher evidence of the antiplatelet interruptions, but from the non-dengue cohort. So this paper actually looking at the bleeding and ischemic events for the adults who undergone non-cardiac surgery. Cochrane's systemic review showed that there were no difference between both arms for the all-cause mortality up to 30 days. Similarly, for all-cause mortality up to 6 months. And the risk of ischemic event within 30 days were similar between both arms. Even though the half-life of aspirin is only 20 minutes, the effects of aspirin may last for a few days up to 10 days due to the turnaround times for the COX activity to recover. In dengue fever, the myelosuppressions and peripheral disruption of platelets causing thrombocytopenia and also the platelet dysfunctions actually may prolong the effect of aspirins. In a nutshell, how are we going to utilize the evidence that we have to approach the anticoagulants and antiplatelets in dengue fever? These are the few situations that we need to consider. Whether the patient has a significant bleedings at the moment, what is the phase of the dengue fever at the junctions, presence of the warning signs or severe dengue, what is the platelet trend, risk of the thrombosis and the bleedings for the particular patients. Hence, the multidisciplinary team approach is needed. And don't forget, we always need to discuss and make decisions together with the patients and our family. If the patients have significant bleedings, obviously we need to stop the culprits, which is the anticoagulants or the antiplatelets. Give the antidotes if available, such as vitamin K for the warfarin, idarucizumab for the dabigatran. fresh frozen plasma or prothrombin complex concentrates, and platelet concentrates, and or plaque cells or whole blood transfusions. Stabilize the hemodynamics is the priority now. If the patients without significant bleedings, I would suggest withhold anticoagulant or antiplatelet in the dengue fever with severe dengue or the platelet less than 50,000. Consider withhold anticoagulant or antiplatelet in dengue fever in febrile phase with warning signs, or reducing platelet train to between 50 to 100,000, especially those actually with high risk of bleeding but relatively lower thrombosis risk. If the situations that require us to continue with the anticoagulants, especially in patients with high risk of thrombosis but relatively low risk of bleeding, then switch the anticoagulants to low molecular weight heparin or conventional heparin infusions when the INA subtherapeutic, if the platelets range 50 to 100,000, or even earlier when the platelets more than 100,000 in a febrile phase, because we expect that platelets will drop sooner or later. Multidiscipline team management with the cardiologist, hematologist, intensivist or NS, patients and the patient's family needed actually for the decision making. Just to make sure we are on the same page. Looking at the clinical cause of the dengue fever, the platelets actually gradually dropping during the febrile phase to the nadir level during a critical phase. And only after recovery, the platelets were expected to slowly increasing after. When we reinitiate anticoagulants or antiplatelet, generally it can be resumed once actually dengue patient in recovery phase and the platelet improving trend to 50,000 and above, unless any specific contraindications. Now we move on to case number 3. 28-year-old preemie gravida at 32 weeks and 6 days. She was referred from private for sepsis. She presented with only high-grade fever for 1 day, without any other specific symptoms. BP on arrival lowish, 90/60, pulse tachycardic 106, afebrile, just took paracetamol. Her blood count HB 12.9, hematocrit 38, platelet 250 and white cell 13.9. Likely this is the reasons why they refer for the sepsis, because of the high white cells with the lowish BP and tachycardic. She was given 2 pints of normal saline bolus in the casualty, repeated blood pressure 100/66, then was followed by the drips 1 pint normal saline over 2 hours, which is equivalent to about 3 mL per kilo per hour. This table shows the clinical and investigations trend according to the time frame. So initially the dengue was not that obvious, or only its appearance on the day 3 onwards when actually the white cells and the platelets started to drop. And they did the dengue NS1 on the day 3, it was positive. What's striking here actually is the bicarb persistently lower side, and it gets worse despite hydrations. You can see the clinical parameters relatively stable, even though the blood pressure lowish and the pulse looks a bit tachycardic. And it appeared to be dyspnea on the day 4 onwards, after much fluids was given, about 4 liters. So what we can see from here is the obviously initially missed the dengue. Second actually is the patients having overload due to the overzealous fluids given just purely based on the tachycardic and lowish blood pressure and the metabolic acidosis. Likely, I think the subsequent worsening metabolic acidosis due to the hypercholemic metabolic acidosis from the normal salines given. After notice the issue with these patients, and the fluids actually was stopped, and the patients actually were transferred to ICU for the non-invasive ventilations. Just to refresh our memory about the physiological changes in the pregnancy. So what happened actually is the dilutional anemia happens when actually the blood volume was much more than the increments of the red blood cells relatively. And the similarly actually for the thrombocytopenia due to hemodilutions and also the increased consumptions, aggregations causing the thrombocytopenia in about 7 to 8% of the all pregnancy, especially the second half of the pregnancy. The cardiac outputs increased by 30 to 50% in pregnancy due to the increase in the stroke volume, increase in the heart rates, and reduce actually in the systemic vascular resistance and also the pulmonary vascular resistance. Here similarly, you can see that the enlarging uterus and the hormonal changes affect on the respiratory functions in pregnancy. The tidal volume increase but reduce in the total lung capacity and the functional residual capacity. So from the blood gases, we can see that in a pregnancy, they have a respiratory alkalosis with compensated metabolic acidosis, especially in the third trimester. The pH will be around 7.4 to 7.45, PCO2 around 28 to 31, and the bicarb around 18 to 21. We observe a higher percentage of severe dengue infections among the pregnant women compared to non-pregnant women when contract the dengue fever. The significant bleeding due to the thrombocytopenia is not that common, but increased risk of hemorrhage in the presence of dengue shock syndromes. What is the risk of the dengue in a pregnancy towards the fetal outcome? This systemic review and meta-analysis show there is various adverse fetal outcome in terms of miscarriage, stillbirth, preterm birth, and low birth weight. However, this meta-analysis done a year later show that there is no adverse fetal outcomes from the maternal dengue virus infections. So what is the truth behind? Obviously, we need more studies to prove that. Now we reach the terminal end of the pregnancy. Dengue infections is not an indication for elective delivery. Majority of the patient actually can allow to progress to spontaneous vaginal delivery. Premature labor can occur during the acute infections. It is advisable to delay the delivery until the acute infections resolve with the tocolytics if indicated and appropriate by the obstetricians. The close fetal monitoring is required in this group of patients to detect the fetal distress, and decisions for the delivery can be made. All pregnant mothers with dengue should be co-managed in the hospital by physicians, anesthetists, and obstetricians. Deliveries should be conducted by the obstetricians or the senior medical officer if it's in a hospital without specialists. Instrumental delivery should be avoided wherever possible, and if indicated, the procedure should be done by an obstetrician. If the decisions of instrumental delivery or operative delivery is met, the blood and the blood products must be made available. Active management of the third stage of the labor in preventing postpartum hemorrhage is required by the use of intravenous uterotonic agents. Avoid the intramuscular injections in thrombocytopenia. Platelet transfusion is only recommended if the manifestations of bleeding, decisions for cesarean sections or instrumental delivery, and the platelet transfusions should targeted to achieve minimum of 50,000 to ensure the maternal safety. In summary, there is no clear guideline available for the management of anticoagulants and antiplatelets in patients with dengue fever. The risk of bleedings need to be balanced against the risk of thrombosis. Multidisciplinary approach is required for these cases. For the dengue in a pregnancy, hematocrit value in pregnant women usually lower compared to normal adult due to hemodilutions. The dengue infections in pregnancy had a higher risk of developing severe dengue and mortality. Dengue infections in a pregnancy has higher adverse fetal outcome. Routine platelet transfusions is not indicated unless there is presence of bleeding manifestations or the patient is planned for procedure. Intramuscular injections must be avoided in pregnant patients with thrombocytopenia. Here is the end of my talks. I would like to thank everyone for your attention.